Hypertension in pregnancy is a common medical condition and major cause of maternal, fetal and neonatal mortality and morbidity. Definition: hypertension in pregnancy is defined as a value of systolic blood pressure more than 140 mmHg and or diastolic blood pressure is more than 90 mmHg. It can be mild to moderate and severe hypertension. Blood pressure measurement in pregnancy. Blood pressure in pregnancy should be measured in the sitting position or in the left lateral recumbent position during labor with an appropriate size arm cuff at heart level and using Korotkov phase 5 for diastolic BP. Manual auscultation remains the gold standard for BP measurement in pregnancy. Classification of hypertension in pregnancy. Gestational hypertension means newly detected hypertension after 20 weeks without any organ damage. Preeclampsia defined as newly detected hypertension after 20 weeks with significant proteinuria. Preeclampsia can manifest without proteinuria. Eclampsia is new onset of seizures in a woman with preeclampsia. Chronic hypertension refers to elevated BP recorded before pregnancy or before 20 weeks of pregnancy. Chronic hypertension with superimposed preeclampsia, it's a new onset proteinuria in hypertensive women before 20 weeks of gestation. Hypertension in pregnancy, important investigations. Urine analysis for protein. Albumin creatinine ratio less than 30 mg per millimole will rule out proteinuria in pregnancy. 24 hours urine protein is the gold standard for quantifying proteinuria. Another investigation is platelet count. If it is less than 1 lakh, then only it is significant. You should know the HELLP syndrome. It's severe form of preeclampsia present with hemolysis, elevated liver enzymes and low platelet count. Coagulation screening. Prothrombin time and activated partial thromboplastin time are required if platelet count is low. Other common basic investigations include liver function test, serum creatinine and serum uric acid. Other important investigations includes ultrasound to assess fetal growth, amniotic fluid index, the kidneys and adrenals. Fetal Doppler velocimetry. Complications of hypertension in pregnancy. Following table showing both maternal complications and fetus complications. Management of hypertension in pregnancy. Non-pharmacologic management. Diet with low sodium before conception. More rest and less work increases placental blood flow and decrease BP. Strenuous exercise is contraindicated in pregnancy as it may potentially decrease uteroplacental blood flow. Pharmacologic management. The goal of drug treatment of hypertension in pregnancy is to reduce the incidence of severe hypertension and decrease the incidence of maternal and fetal complications. Important drugs. Central adrenergic agonists, also called as central acting agents. They lower heart rate and reduces the blood pressure. Example, methyldopa. Dose 250 to 750 mg TDS. It is non-teratogenic. Side effects: disturbed sleep, drowsiness and decreased salivation. Clonidine. Dose 75 to 300 mg TDS, alpha-2 adrenergic agonist. Safety and efficacy equivalent to methyldopa. Side effect: can cause embryopathy, should be avoided in early trimester. Beta adrenoreceptor blocker. Control maternal BP effectively. Beta blockers are not associated with teratogenicity. Leptalol, dose 100 to 400 mg TID. It's non-selective beta blocker with vascular alpha-1 receptor blocking properties. Side effect: may cause fetal growth retardation by decreasing uterine blood flow. Alpha adrenergic blocker. Prazosin used only in cases of pregnancy with pheochromocytoma. Calcium channel blockers. Used to treat chronic hypertension, preeclampsia and severe hypertension associated with preeclampsia, for example, nicardipine 10 to 30 mg every 6 to 8 hours. Diuretics. Its usage discouraged because of volume depletion. Furosemide is beneficial in women with preeclampsia in postpartum period. Direct vasodilators. Hydralazine, dose 25 to 50 milligrams 8 hourly. Non-teratogenic. Side effect, few cases of neonatal thrombocytopenia and lupus. Nitroprusside. Useful in cases of refractory hypertension associated with heart failure. Isosorbide dinitrate. Decreases BP while maintaining cerebral perfusion, which decreases risk of ischemia. Angiotensin converting enzyme inhibitors and angiotensin receptor blocker. These drugs are contraindicated in second and third trimesters, as they can cause fetal death and neonatal renal failure. When preeclampsia is associated with pulmonary edema, nitroglycerin is given as intravenous infusion. Intravenous labetalol and hydralazine are effective in hypertensive emergencies in pregnancy. Magnesium sulfate is the best drug for both treatment and prevention of seizures. It can decrease the BP up to some extent. This is brief video about important antihypertensive drugs used during pregnancy. Thanks for watching.